Brian joins us with 20 years of experience in both the pharmaceutical industry and the nonprofit industry. He's currently with LLS now, where he leads their regulatory and legal affairs, looking at both federal level issues and state level issues. Brian has experience in, I'll just abbreviate it to say, public-private partnerships, and a perfect resume and background for the work that you do both at LLS and that you're going to be facilitating here today. So thank you for joining us, and I'll turn it over to you.
Okay, so now we get to talk about pathways and guidelines, and Lauren gave us a very good warm-up this morning and gave us some definitions. So again, I'm Brian Rosen, I'm with LLS, and before I introduce our very highly distinguished panel, just a bit of background here on pathways. So you heard one definition this morning. The definition I've been using, and from Webster's, formalized protocols driven partly by therapeutic outcomes and partly by economics. I think that was simplistic enough. It doesn't necessarily capture everything we're going to talk about. But, and again, I think we heard this morning that they were offered primarily by payers, but in addition to insurance plans, we've seen them from specialty distributors and even from third-party consulting organizations. So the interesting thing is that at the same time as that you have these pathways, you have incredible improvements in many areas of cancer. And we have beginnings, at least, of a shift in paradigm from managing acute illness with limited duration of time to moving, hopefully, to more chronic illness with much longer durations of months and years. So that brings up the question that was started to be raised this morning, which is this nature of cancer. And we have great variability even now from patient to patient, driven not only by overall health and morbidity and behaviors and adherence, but also by genetics and genetic mutations. And we do need to recognize that whatever system we move towards, that we have to take into account patient individuality. So I think want to keep that in our minds right now as we speak with the panel and we hear what they have to say. And then on the other side, we have studies showing that there has been statistically significant treatment cost reductions from some of the pathways that have been implemented, reduced duration of treatment, lower rates of chemotherapy in the hospital, lower frequency of additional medications from some of these pathways. So there have been some really good signs that we need to recognize in some of the pathways that have been administered. So there definitely, I think we can all agree that there are pros and cons with our guidelines and pathways that we're going to discuss today. So with that, I'm going to welcome the panel. I'll do the same as Lauren did this morning. I'll read a very brief bio for each of our speakers, and then maybe ask you each to just give some kind of opening remarks here on your experience with guidelines and or pathways. So I'll start with Dr. Robert Carlson. Dr. Carlson's the CEO at NCCN, the National Comprehensive Cancer Network. He joined as CEO in 2013. Before that, he was professor of medicine in the Division of Oncology at Stanford Medical Informatics at Stanford University Medical Center, as well as the medical director of inpatient oncology and hematology at Stanford Cancer Institute. He's a member of several medical societies. He's authored and co-authored over 140 articles and abstracts and chapters that have appeared in publications of NCI and the Journal of Clinical Oncology and the Breast Journal. So, Dr. Carlson, do you want to give any remarks, or do you want to wait until after the intro?
I'll hold my remarks.
Okay, we can do that. Our next speaker is Ted Okon. Ted is a nationally recognized expert on the policy and politics of cancer care. He's been quoted extensively in the press. He's had guest appearances on TV and radio shows. Ted's testified to Congress on cancer issues. He's frequently on Capitol Hill discussing our cancer care delivery system. Target areas of expertise include cost of cancer treatment, healthcare reform, Medicare reimbursement, drug shortages and the changing landscape of cancer care delivery in the U.S. In addition, Ted is the executive director of COA, the Community Oncology Alliance. He oversees the strategic direction of this organization, nonprofit organization dedicated to patients and providers in the community cancer care setting under the direction of a dedicated board of oncologists and practice administrators. And Ted has authored numerous articles and studies relating to cancer care policy and politics, reimbursement, and clinical issues. So happy to have Ted Hogan. And finally, our third speaker is Dr. Ira Klein. Dr. Klein is a national medical director at Aetna in the CMO office and joined Aetna in 2006. Dr. Klein leads the oncology solutions team and other enterprise-level strategic initiatives. Previously, he was the medical director for quality and case management at Bayshore Community Health Services, and before that, the chief medical officer of Elder Plan, a Medicare social HMO. So we are happy and welcome Dr. Klein. So Dr. Carlson, maybe I'll start with you in terms of if you'd like to provide some opening remarks.
Well, I'm just pleased to be here today. Thank you for the invitation. As you can imagine, being from NCCN, guidelines are near and dear to my heart. They're the core of what we do. We do have a number of relationships with pathway companies as well. And as many of you know, we have co-branded to some extent with McKesson Specialty Health for the CBP Plus pathway system. So we are also gaining experience and perspective on the use of pathway systems within oncology as well. I think the issues are complex, and I look forward to this discussion.
Thanks, thanks, Brian. Thanks for having me here. I think I'll just make a couple opening comments. Number one is I'd actually like to sort of correct a little bit or modify something that you said in terms of the interesting thing is I know there's a lot of focus today, and not just today, now, in terms of pathways on the payer side, but actually there are a lot of oncology practices that have their own set of pathways. I mean, if you go, for example, to Northwest Georgia Oncology Specialists, about 22 oncologists up in down in Marietta, Georgia, you will find a very extensive pathways that are, first of all, and I just don't give this as lip service, especially this audience, but really is built on patient choice, first of all, and outcomes, and then secondarily, sort of the economics around that, starting with the patient economics. So the interesting thing is, if you go there, you go to the Zangmeister Center, I mean, I can spot you all around the country of where you actually have it on the payer side. I think one of the things that we need to sort of talk about and come to grips is not just as Bob said in terms of the whole idea of guidelines and pathways, and we're very fortunate to have really the gold standard in terms of guidelines with NCCN, but the fact is there's proliferation of pathways now, and it's something that Ira and I have talked about a lot. We had a summit here recently in DC with provider payer teams. We're going to tackle this some more, but it's as you have payers that have their own pathways. And so Dr. Bruce Gould, who is the head of that practice, as I said, in Marietta, Georgia, he literally has to deal with 6 different pathways. Now, I'm not the clinical person, and I'm certainly not the clinical person at this table, but I will tell you that it's bad medicine, and it's just flat out wrong. So I think we have to solve some of that in terms of coming to grips with it. And I think the other thing is, and everybody knows it, and I'll get it right out there, is there's a lot of concern now about the WellPoint pathway, where we're going to pay physicians to sort of follow that pathway. And I think that's a problem that we have to deal with. So I think, as I will underscore what Bob said, there's a lot of issues that we need to deal with on this pathway thing. And I think the other thing is that pathways should not be the end-all be-all. They are right now. And they are right now because even though, as Lauren said, the drug piece is 21%, let's face it, it sticks out there, it's something in the news, 60 Minutes, everything. So everybody focuses on that and really doesn't focus on keeping patients out of the hospital and hospitalizations, which are, what about 46% or something close to 50%. And not only that, but from a patient perspective, the last place I want to be with cancer is in an emergency room or even hospitalized. So, a lot more, but those are just some initial thoughts, Brian.
Thank you.
Well, I think I've had the luxury of being able to be the third speaker, and so what I'd like to do is try to bring us back a little bit to how did we get here? And as someone who began his career as a hospitalist for almost more than half a decade, I saw those patients in the ED, and it was horrible. What are payers doing? I don't know if I can represent all payers. I can tell you what we're doing. I think there's some commonalities. You should know that the private insurance world is really about bringing together supply and demand. And the supply are the providers, physicians, allied health professionals, hospitals, bricks and mortars, other entities in the delivery system. The demand are patients, people who sign up for health insurance or get it in a public or private manner, and they expect services. And up till now, the insurance function has been fairly traditional, just bringing them together through an insured mechanism. You get a card, you pay a claim, you pay premium. All right, that's kind of where we are, but as we said this morning, that's unsustainable. And the reason it's unsustainable is because the changes in society are causing our suppliers to need to take risk. ACOs, shared savings deals, things like that. And the reason is because everyone's agreed there's no more money in the system. So what about on the demand side? So you all have insurance cards, and I think you've noticed that not only have your premiums gone up, but your first dollar out of pocket has gone up. And so on the demand side, what's happening is there's defined contribution, which may be where the ACA takes people in the exchanges, and you're spending more money, you're risking more. And I think the number brought out this morning was 23% or 27%. It's a lot of money. So in those things changing, we on the payer side, and me specifically in oncology, are tasked with trying to get the triple aim goals met. And I think guidelines and pathways, as Ted said, are part of the solution, and it's part of an evolving solution. And I'll tell you why. We began in 2009 working with US Oncology on their system that had an EMR and a pathways program. And we found that it looked like it was doing some both economic and clinical good. And so we ran some pilots around the country with several different vendors. We don't build our own pathways. We go out into the marketplace, look at what a market is doing, try to get one that tries to minimize the burden, as Ted pointed out, of 6 pathways per company, per practice. But so we've sampled a bunch of different companies and their products, and we found that it worked. And it worked not really because of the drug part. Sometimes it worked because of the drug part in year 1. But actually it worked because of what was said earlier today about workflow. When offices figured out how to organize themselves to be more efficient in order to make sure patients got, for example, the appropriate adjunctive medications to minimize nausea and vomiting, to get appropriate growth cell factors. When this was systematized and the work was handed off to mid-level providers and others in the office so everybody worked at the top of their license, you got less people showing up in the ED, more people who were educated about what to do with symptom management, and you had a more efficient office. So think of this as something that was transactional, not something that was of great value in itself. Yes, in some cases there were some shared savings on the drugs, but that's always minimal because after 1 year, you get back to that same baseline. So we're now taking that and building on a national strategy, which really is going to be as much oncology medical home focused from what we've learned as it is pathways. In parts of the country where you have 1, 2, 3, 4 physician practices, they don't know what to do. They'll get pathways. And what will that do? Will it be the end? No, it'll just be the beginning. Because what it'll do is give them the systemization to allow them to move to a place where I think our CMS friends want us to go in 2 or 3 years, which is episode payment. And as was stated this morning, episode payment is very complicated. However, it can be done. What needs to happen is there needs to be significant data aggregation, marriage of the clinical and financial information. Once that is completed, then you can actually look at what you can do to create this and make it patient-centric. Because, also said this morning was it's about the best experience for the patient as well as the outcome. So if you bake in quality measures that make sure that people can't both undertreat or ignore the patient, and you can't get that money unless you do that, you will actually get people to think in ways that make them pay attention to the patient. So I'll stop there. But I just wanted to level set about where we are, and at least on the payer side, what we're thinking.
Great, thank you all. Dr. Carlson, I guess, lost in the discussion today, this is guidelines and pathways. And I feel like everything's pathways. And when I grew up in the biotech industry, everything was about guidelines, and specifically NCCN guidelines in oncology. So I just want to kind of ground us here from your standpoint, and maybe talk a little bit about treatment guidelines, not only what goes into the development of these guidelines, but how is NCCN seeing that those guidelines are used appropriately, and what are they intended to be, and what are they not intended to be?
So let me start with what I would envision a definition of a guideline is, as opposed to a pathway. So a guideline is a systematically developed document that is aimed at improving the decision-making of healthcare providers and patients.
Is it on?
Is it on or are you not close enough to it?
Wow,
It's on.
You said to get closer to it,
I
right?
think is it on? I don't think so.
Let's go with this one.
Looking at the mic, I hear the back of the room.
If I bring that up here now, want to do that?
Okay, gotcha. Yeah, as soon as I get close to that. Sorry about that.
No, it's definitely not on.
It's not on.
Just do this one. There you go, Ted.
It's not, let's see if we can do this without knocking the
We,
flower over.
it will be easy if we can take the flower.
Look at the panel, guys, get rid of the flowers.
We don't need flowers.
So solutions
oriented.
I just want to make an announcement. I'm the one in our house most of the time to make sure we have fresh flowers on the table.
Thorn among the roses.
Now it's working.
Oh,
Here we
good.
go.
Thank you,
Okay.
sorry about that.
Technology.
All right, so we're going to talk about guidelines.
So guidelines, systematically developed documents with the intent of assisting the decision-making of healthcare providers and patients. Developing the guidelines, there are different processes between the guidelines development process and the pathway development process. So let me outline a little bit what we go through in terms of guidelines development. So the first thing you have to do is you have to bring the right experts to the table. There are individuals who say that the people at the table for developing guidelines should be non-experts. That's what the Institute of Medicine says. But the challenge there is that about 60 to 70% of the decisions that a medical oncologist or hematologist makes every day have no high-level evidence behind them. And so if you're going to have a guideline across the continuum of care, you really need to have experts fill in the gaps between the evidence. You don't want the bus driver driving or flying the 747 that's going to take you home.
Right.
You need somebody that knows what they're doing. But the panels need to have all the representation from all the appropriate modalities or specialties that are applicable within that specific oncology domain. And we include in our panels patient advocates as part of that perspective and that expertise. You then need a transparent process for collecting data or evidence that you're going to analyze, for getting feedback from the different stakeholders in terms of their perspectives on that evidence. And then you need a systematic way of evaluating that evidence and then codifying it into a guideline, where you are honest and you evaluate the level of the evidence, how much agreement there is among the experts when you're in a situation, especially where there is no high-level evidence, and you need it reported in a predictable way. It needs to be easy to use at the point of care. It needs to model the way that healthcare providers think, so that they can use these documents very, very efficiently in their everyday practice. And then once you've done that and published it and published the
a manuscript that supports the sort of algorithmic recommendations as we make them, the whole process starts again. And the process also needs to be very, very responsive. In the oncology space today, a guideline that is updated every 2 to 3 years is not useful. It's not useful. We update our guidelines on a as reported basis. So a new FDA drug approval, a new Sentinel study reported in a peer-reviewed form, and so on. Our panels will meet immediately and modify and update the guideline. We can go in 24 hours from proposed change to a guideline to a change in our guideline published on our website. And that's with committee panel review. So you have to have a very, very efficient process, otherwise the guidelines, again, are just always out of date, and they're not useful. What are they intended to do? They're intended to improve the quality of patient care, of the patient outcomes and experience. I mean, that's just very, very pure and simple. I'm not going to talk a lot about pathways yet, because I know there are people on the panel who have expertise in that besides me, except to say that I think it would be fair to say that all of the for-profit pathway companies in the United States use our guidelines as their starting point, either with or without license.
Why do they need to modify them?
That's a good question. And I think we'll have a lot of perspectives on that. So, okay, you asked the question. So, why do they need to modify them? I think that if I were a payer, I would want to restrict choice so that things become predictable. And from the perspective of a payer, having a pathway that all of your clients use is very predictable for you, and it decreases variability of care for you, the payer. But what does it do to the other constituencies? The challenge there is, you've just heard that Bruce Gould uses 6 different pathways in his practice, and those choices are going to be restricted. And because those choices are restricted and what they have to use, as the provider, having pathways actually increases the variability of your care. Not decreases, increases the variability of your care. And it not only does that, but it does it in a way that disenfranchises the patient, because the patient now also has fewer choices. The outcomes that were of importance to the patient are not necessarily ignored, but they're not considered in culling the choices. And so the patient ends up being totally disenfranchised from that. In addition, with I think one notable exception, none of the pathway groups have a transparent process. For most of them, you cannot tell who even developed the pathway. They have no transparency to the way that they collect data or that they analyze data. You have no assurance that a disease expert even looked at the recommendations that were made. If you dig deep, most of the recommendations are actually developed by nurses, not physicians. Some of my best friends, including my wife, are nurses. They're important people, but their perspective is different on approach to patient care. And their conflicts of interest are not disclosed. The conflicts of interest are not disclosed. So it tends to be a very opaque process, as opposed to one that we use and other professional societies use in developing guidelines. It tends to be very, very transparent.
Okay. So, Ted, you said something interesting. I wasn't really aware about all these provider pathways. And I guess in my mind, I'm thinking, okay, now you have a provider who's creating their own pathways. Coupling that with they have contracts with 6 different payers, all of whom may have pathways. It seems like it can get pretty complex pretty quickly, and the question is, are there too many pathways, and how can an oncology practice operate efficiently in this type of environment with multiple competing pathways? We heard the example earlier this morning. You talk to one patient, you say, oh, here I have to do this for you, but something completely different for someone else.
Yeah, I think we have to solve that. I think that's a problem, Brian. I think the bottom line is, I look at pathways, especially when it's constructed by the physician within a practice. Why are they doing that? Because basically trying to pull some of their wisdom and literally narrow down things like what they would look at in terms of the guideline process. And again, the beauty of what we have in cancer care is we have the gold standard in terms of NCCN guidelines. I think what happens is that in a practice, why do you go to pathways? Because number one, you're being more specific and there's a pooling of what you think works in certain types. But let me tell you right now, because I know what a lot of people are thinking, and some of the practices that have really early on developed their own pathways, looked at pathways, have done that with a mind to, at best, not being a cookbook. Because some of you are thinking, oh, this is a cookbook approach, it's not, goes against personalized medicine. No, it leaves that out in the open, but if you look at cancer care and you look at certain things and certain types of cancers, there are very predictable things that you want to do, and if you can pull the evidence of that practice, and if you can take that practice and reduce some of the variability, because remember in oncology today, there's new stuff happening all the time. So it's important that you have something like, and you have the ability, and we have the advantage of having NCCN be able to literally, in a 24-hour period, sort of update the guidelines. But the problem is that, it's tough for oncologists to keep up. And in a well-groomed, greased practice, if you will, where they're pulling their evidence, where they're having discussions on their pathways, I think it's actually very productive. The other thing is, what pathways pull in, is they pull in an element on the cost side. And I'm not just talking about the cost side in terms of, where the practice is going to make the most money. I mean, we hear this perverse incentive nonsense all around. And that's why, you have over 300 cancer clinics that have closed facilities, and you have close to over 450 practices that merged into hospitals because it's so profitable to give chemotherapy. It's not. The bottom line is that what it allows them to do, though, is when you look at alternatives and you say all else being equal, and this is what we believe, then when you can select the less expensive product, which that's what they're baked into a lot of these pathways, that's the best for the patient, because it's the patient that's paying the 20%, 30%, 40% copay as well too. So I want to underscore, I don't think pathways are bad, I think they're really good. Where I have problems and get into it is where you're crossing the line and you're breaking that physician decision making, and certainly that physician patient sacred bond, and you get into it from the standpoint of others that have gotten into the business. And that's how it started. Let's just be very transparent. I mean, there was an entrepreneur out there that some of you know who said, oh, this is great, if I can do these pathways and I can make a deal with the payers, I can get a lot of money. Well, guess what? That entrepreneur sold his company for $500 million. And I think, frankly, that is the wrong side of it when you talk about sort of the business side as opposed to the patient side. And by the way, I too have a nurse as for a wife. She's an oncology nurse. She's administering chemotherapy right now. And I can tell you, whenever I talk any gobbledygook that isn't directly focused on the patient choice and stuff like that, it's a very icy household that night. So, and there's no joke about that. Hence the flowers, exactly right. Now you do the connection. There's a reason for that. So, and I mean that in all dead seriousness. My wife doesn't mince around. So I think what you should keep in mind, pathways I think are not evil. They can be important. It's a question of how they're done, who does them. Who creates the pathways. And I do think we have a real problem. I mean, Ira and I have talked about this for a while. I think we have a real problem with pathway proliferation, just like we're going to have a problem with quality guideline, quality measure proliferation and all this. You cannot practice medicine, again, as the non-clinician here, you cannot practice medicine and figure out, oh, that's Mary Smith. Even if I have the best EMR, that's Mary Smith. I give her one drug because that's this pathway, and here's Tom Jones, presents with almost the identical cancer symptoms, everything else, comorbidities, and I'm giving another drug.
Ira, all the arrows are pointing to you now. So I guess, first of all, do you have a wife who's a nurse?
Well, actually, my wife has a doctorate degree in pharmacy.
So,
And as Mark Robbins will tell you, when we were in pharmacy school together, she was smarter than both of us.
and you don't have to limit your answer to just this question, but I'm curious. You know, the idea of the individual patient, you know, who comes in and you have a pathway. There's a pathway that's set up so that that patient should get X treatment. But this patient could be disadvantaged because maybe the more costly drug that's maybe not on pathway might be the one that works better for this individual. Again, this is maybe even mutation based. And I've had this conversation with your colleague, Michael Colleget, and I think it was him who said that, well, if we can get, you know, providers to be 80% compliant with pathways and still leave a little bit of flexibility for them around the edges or with the other 20%, maybe that's how we solve this. But again, if we're really getting towards more individual, customized treatment with biomarkers and so forth, does that solve this? Does that address the individual?
Actually, I think it more reinforces the need for some kind of clinical decision support tool at the point of service, meaning where the doctor sees the patient. Now, Bob, check me if I'm wrong on this. Isn't it true that about 50% of all practicing oncologists now are over the age of 55?
I think it's in that range.
Yeah.
We're an old group.
Yes. So you have a large cohort of physicians really working hard to take care of patients who trained 30 years ago. And most of the breakthrough innovations in oncology have happened in the last 20 years. So if you add on top of that genetic variations and the ability to do personalized medicine, I think it'd be pretty scary to be a patient and not have some kind of electronic up-to-date tools. Now, all of the tools that are out there are based on NCCN guidelines, including all of the mutations that have FDA approval. And so it's good to get it right. As Mike probably said to you when you asked him that question, it's good that the airline pilot who is on the plane that you're taking off in went through the checklist. You don't want them doing it per the art. So if you're a patient, you're going to get the best therapy based, number one, on efficacy, best efficacy, number two, lowest side effects, number three, cost. So, you know, we do have people who understand this go through these. We won't accept anything that is less than best practice in that regard. And I think for support for the patient at the time of treatment, this is actually a good thing. And I don't see any, I don't understand the, you know, the patient choice is restricted. What we found actually is that patient care is improved because the pathways also remind people what appropriate supportive agents to get, which antiemetic agents to get, when to get, granulocyte colony stimulating factors appropriately. And we know from pulling our payer data that before this, it was all over the map. So if you're a patient and your physician is looking at something that's clinical decision support software, you should actually be glad.
Do the patients get to see those pathways?
They can. I mean, this is pretty transparent, and as Bob said, it comes from NCCN guidelines. It's not less than good therapy. It's always level 1 NCCN when possible.
So what about the others? I'm just curious, and Ted, feel free to comment on anything here, but should these pathways be transparent to patients, or is that too much information?
I think it's a rare patient that if you pitch it correctly, gets too much information. And I think that there are some patients out there who are very sophisticated healthcare consumers, even nurses or physicians or pharmacists, who, if they were told that their choices were being restricted from 20 different choices to 3, you know, pick one of these 3, who wouldn't say, well, why, I like this 4th one, why can't I have this 4th one? Who wouldn't want to actually see the rationale for that restriction.
Well, I'm glad you said that, but Ted, I think that most oncologists, I'm just gut check here, I'm thinking that they would say, no, they don't need to see everything out there, and they don't need to see the entire treatment pathway. I can explain what's appropriate.
I think so in a way, Brian. I mean, I think I don't want to play physician, but I think in some cases it's tough because when you look at some of these, it's just absolute overload. How do you make any head or tail if you don't have any kind of advanced degree, especially in medicine? I want to underscore two things. One that Iris said, one that Bob said is number one is I think Iris is absolutely right that one of the things you should think about the advantages of pathways and even guidelines moving down specific pathways is they do provide in essence sort of a checklist function, which is really important. So when I get on that plane, as I did yesterday, I mean, I want to see that pilot who's walking downstairs and going through all the checklists about, you know, is the fuel, is there enough, are the bolts tightened and everything else, and seriously, that's really important. So I think that's one aspect, totally agree with. But I think Bob made another point, which I think is a problem and an issue, and it's not necessarily the transparency, Brian, at the patient side, it's just the transparency. So one of the problems I have, because pathways have gotten to be a business as well too, not just a medical tool, is of course they don't want to have them being transparent, and I have a real problem with that. I can understand I'm the biggest, you know, commercial free market guy in the world, but here's an issue where I think there's a problem. So we had a payer summit that Ira, others participated in, what was 3-4 weeks ago, and there was a discussion about this pathway proliferation, and one of the payers actually said, well, you know, my pathways are transparent. You can go on the website. I try to go to see others, and I can't see them, but yet we're making statements like, well, the pathways are essentially 80% the same. Well, how do you know that if you can't get on to see? So we've got some things to do, and the good thing is, I can tell you, you know, 5 years ago, if you put a payer and provider in the same room, you'd first have to have them check their guns at the door and basically body frisk them. And you know, now we are having some of the best discussions really in the world trying to solve a common problem. Because I will tell you, cancer care in this country, for all the good things that are happening, is in a crisis mode. It is in a crisis mode, and we're trying to solve some of these things. So I think transparency is key starting at the provider and at the pathway level. Forget about even getting to the patient.
So some of my best friends are payers too. But I also think that there is an inherent conflict of interest between the pathway companies and the payers. And that inherent conflict of interest is who pays the pathway companies? It's the payers. Do you think a pathway company is going to want to upset the people that pay for their product or pay their salaries? Absolutely not. You know, again, most of the major professional societies, and certainly NCCN, we have a rigid firewall around our guidelines program. Not a single dollar of payer money, not a single dollar of industry money goes into our guideline development. It's all paid for by the dues of our member institutions. And we do that intentionally, and we continually monitor that firewall at headquarters, I can assure you, because we don't want to breach it. Because once we breach that, the credibility, we believe the credibility of our product will suffer. And yet, that's what, without exception, the pathway companies do, is they breach that firewall every day. Now, it doesn't necessarily mean that what the conclusions they're coming up with are inappropriate. Because you can be conflicted and still make a proper decision. The challenge is that you then, especially if the process is not fully transparent, you then have all the more uncertainty about what considerations really went into that. And if one therapy is less expensive than another, and that's why the pathway company went with it, well, is it $1 difference? Is it $100,000 difference? You know, what really is the basis of that difference?
Did you have something to add?
Oh, but just on this is that when we've reviewed these, they come off level 1 evidence from NCCN guidelines. So it always is the highest level of evidence from your guidelines. So there is really no skimping on care. I think we need to explode the American myth that more expensive is better. More expensive is not better. Better is better. And that's how we do it. And with regards to the proliferation, the messiness of the whole pathway world, innovation is messy. So if we're going to stay where we are, we can complain. If we're going to move ahead, we'll have a little bit of messiness. I do think that messiness will be cleaned up in the next 2 to 4 years, because I actually think on the IT front, we will find appropriate crosswalks and ways to translate evidence today into reporting that is very transparent and easy to see, that gives guideposts for people to know where they should go. And actually, as I said before at the beginning, this will be the evidence and the data needed to build episodes that make sense. And it was very interesting to hear this morning people talking about episodes as if the sky was going to fall. I think if we rolled the cameras back 30 years, this or 40 years, this is what they said about DRGs. Well, the sky didn't fall. It actually worked out okay.
So I read 6% of the recommendations on the NCCN guidelines are category 1. 6%. So that's not a deficiency of our guideline, it's a deficiency of the evidence base. But what that means is that 94% of the recommendations are made on less than high-level evidence. And I do agree that if we ask all the medical oncologists, probably everyone in the room for that matter, to compare different treatments in those circumstances where there was really category 1 evidence, you don't need an expert to say that those 2 treatments are equivalent. But that's a very small minority of the decisions that are made. And when you get into areas where there's lower level evidence and it then becomes expert recommendation and so on, that's where your conflicts of interest tend to shine. And I do believe that most of us are not even fully aware of what our conflicts are. We choose to call out the financial conflicts of interest, and those probably are substantial conflicts of interest. But there are others that we're not even aware of, and that's part of the reason for, I think, wanting a large group of people who are making the decisions, the recommendations, so that the unusual, undetectable conflict of interest sort of gets washed out in the average. But if all of our recommendations were category 1, we probably wouldn't need a guidelines panel to start with. It'd be really easy, very straightforward.
So just to jump to on the financial piece, since no one's here from WellPoint, let's throw them under the bus.
Sorry, Jim.
I've heard Jennifer Mallon speak about their pathways and $300 incentive payment, and I've heard her say that that their physicians don't have to follow these pathways. They can go on having done what they've done in the past and not receive this bonus payment, but they're not penalized in any way. And then I'm thinking and saying, well, aren't all of the pathways or many of the payer pathways based on a reimbursement? Maybe they're not set up the same way as an incentive payment for a particular decision, but they ultimately all have reimbursement implications that are involved. How is the WellPoint model so different or so maybe problematic or concerning?
Gee, I really don't want to speak for someone else. I'll just say that when I talked about pathways at the beginning, I said that this was part of a process of practice transformation. And that's probably more important than the specific choices and regimens, because it's about systematic change. And so we're really moving to an oncology medical home model where you will have some software inside. And as Ted and I have discussed, I think that over time, better solutions will happen that are actually very easy for the workflow of the office. But the main thrust is to get efficiency in the office. Everybody works at the top of their license. Patients get called back after first day of chemo and regularly after that. There is, at the end of treatment, a data packet that gets printed that's patient understandable. It says, you're a survivor. Now you have a packet so you can go back to someone in the system and they know what you got. There's a lot of features that are hard to transact without somebody doing the software innovation. And so We don't want to do it ourselves. I mean, you've had my colleague Mike talk a lot, and he's already done pathway development with US Oncology for 10 years. He doesn't want to do it. We basically would rather kick the tires of somebody who can show us a good organization of highest level evidence. And Bob is right, you know, you've got level 1, level 2A, level 2B. If people can demonstrate that they're doing it the right way, we don't want to be in that software business. We'd rather buy it, and then if it's not working, we get rid of it. So this is where the innovation being messy comes in. Do we think that the patient community is, quote, being experimented on? No, we think you're getting better than you got before, but it's not the ideal end state. And as was also stated, perfection is the enemy of the good.
And you said you're trying to bake in quality measures from the patient perspective?
Oh, yeah, yeah.
So can you just talk about that for a second?
Yes, patient satisfaction measures include not just the obvious, which is patient satisfaction survey, but also the other sort of obvious fact that if you're in the hospital and you have an avoidable side effect, that's not good quality. So we're measuring hospitalization rates and ED visits. And in the medical home, we're also looking at aspects of care that include counseling on oral oncolytics, drug therapy side effect counseling, how to self-manage, counseling on what to do with metastatic disease, do you have advanced directives, and then also 1 or 2 measures having to do with hospice and chemotherapy in the last 2 weeks of life.
Yeah, I mean, I think all that is being done basically in spades. I mean, on our oncology medical home, we have a steering committee, and on our steering committee, actually, Iris sits on it as one of the payers. We have providers on it, and we have patients, and we have patient groups. That was a big thing. And if you go talk or you ever hear Dr. Bruce Gould speak, who was actually the first chair of the steering committee, the first thing he did was talk to patients. Not just like he does every day. He went out and talked to patients. The practice on their own dime actually hired someone to hold focus groups with patients to ask one simple thing. What is important from cancer? Not an oncology medical home, not anything mumbo jumbo. What do you want? And it actually brought in a lot of those experiences that Mark brought up on the panel earlier today were really important. What's kind of interesting is that if you've ever seen Bruce Gould's slide, it has a column for patients, then it has providers, and then it has payers. It is remarkable how those match up. I mean, down at the bottom, they get a little difference in terms of, because you have maybe have someone in a public company, you have a physician who's under pressure, so you get little different things. But it starts right out with outcomes, right across the board. And so what we did in that was looked at quality measures, and we have a set of quality measures that Ira and everybody else has been involved with in terms of very workable that start with the patient and are literally patient-centric. It doesn't have anything to do with the practice, doesn't have anything to do with the payer. It starts with the practice, and part of that is patient satisfaction. I mean, we've been working with the CAP survey. We're now modifying the CAP survey because CAPS is saying this will be a sanctioned oncology CAP survey, and we have close to, the other day, we had 32,000 completed surveys. I mean, and this is not just something we hand out, patient gets. The beauty of this is the practice administers it. They decide when to administer it at certain times. They've talked to their patients about it. And it is a beauty to see because it literally allows physicians to be benchmarked within the practice. And you see some physicians who score low on certain patient satisfaction. And I've talked to those physicians and it's been an eye-opener. The practice can benchmark itself against other practices. So the thing is, you will have physicians who balk, oncologists balk, well, patients are satisfied when they come, they get their scan, it's good. When their scan isn't good, they're not satisfied. And I argue that a lot, again, as a non-clinician, and what's the beauty of it is now, we're seeing something that is very widespread, literally that starts with the patient, talks about the patient. And I want to say one other thing, Brian, because I totally agree, Ira and I have talked about this, a point that he made, is that if we focus on pathways, guidelines, so therefore we also focus on that, Lawrence, 21% on the drug side, we have really, really missed it. The drug is easy to focus on. Again, 60 Minutes, Leslie Stahl did a wonderful story. I was involved in that, so I won't go into that. You talk about a setup job. My other day, my wife had 60 Minutes on. She said, "Are you going to come watch?" I said, "I will not come in the room." How do you know that she's talking about water? You're going to believe it when she couldn't even talk right about drugs. Other story. But I think that it's easy to shoot holes at that. And yes, the drug piece is important. Yes, drugs are going through. We have a problem. I say to Mark and and Alan, all those on the industry side, we've got to grapple with this. We can't have these costs exploding like that. But I will tell you, the rest of the experience, starting out with the hospital and hospitalizations, are absolutely key here. So when we talk about guidelines, we talk about pathways, we have to put them in some context. And I believe, not just because we live and die and I wake up in the middle of the night thinking oncology medical home, but I think it does give a beautiful framework that is patient-centric. It's not practice-specific. And one other fast thing is, all my oncologists, none of my oncologist friends are in the room, that's good. But the bottom line is, our model of medical care in this country is the queen bee model. There's the physician and everybody else buzzes around. And you have, all the other worker bees, the nurses, social work, everybody buzzes around. You will see in the oncology medical home and some of the practices that are implementing this, that model's breaking down. And it's actually being focused not on the oncologist, the provider, but on the patient. That's the beauty of this. So, off soapbox, sorry.
Anyone want to talk about 60 Minutes? No? Okay, so Bob, did you have any other? Okay, so we have just about 5 minutes.
10 minutes, we're good, Jeff.
Okay, so wanted to open it up to the audience and see if you have questions.
Hi, I'm Ian Hubbard with the American Society for Radiation Oncology, and we've been talking with our members about guidelines and the importance of pathways as tools to improve value and quality of care. And every time we have these conversations, some of my docs say, you know what, the reason why we're here is because of the outliers. There were outliers for overutilizing and inappropriate utilization. Why didn't the payers go after the overutilizers? And I just wanted to pose the question, what about the overutilization and the outliers? How are they being handled?
Okay, so now I'm in the weird position of trying to say that we didn't do enough oppressive oversight. I'll do my best on this. You know better than I do that radiation oncology has a series of 800 or 1,000 codes that are submitted, and maybe per each patient experience, about 400 of them are used. And it is true that there is outlier behavior. When something is not a huge medical cost category, it essentially is business as usual at the payer side. But when a cost rises and the rate of rise is very high, as it's been in radiation oncology in the past decade, due to IMRT, stereotactic radiosurgery, proton beam, and other new modalities, then we pay attention. So our claim systems were not set up for this. You submitted, how many codes per week? 50? I don't know, a bunch of codes. Treatment codes, planning codes, all kinds of codes. It's become an issue. We've talked to Astro about it. That solution will likely be, for almost all payers, vended out. We don't want to change our claim system. We don't want to hire a radiation oncologist. We will hire a third party to do the audits and take care of it.
So I should tell them they floated under the radar for a while.
Well, I think the thing is that people complain, but then my response is, then police your own. Who's responsible for this problem?
I would also add that it's often difficult to understand whether the outlier is an outlier in a good way or a bad way, unless you have a benchmark, like a guideline or a pathway that you can say, there was agreement that this was appropriate care. This is your data in terms of your concordance rate being 10%. Work on it.
And that's one of the things that we've started doing is benchmarking different modalities and understanding, are there outliers in certain areas and not others. And it's been interesting. But part of it is just having the data to look at.
Yeah.
Thank you.
Yep. So I have a question. First of all, I'm going to disagree with Dr. Carlson on one thing, and I think Deb will get my back as an oncology nurse, that if nurses created the pathways, and especially the WellPoint pathways, when you look at adjuvant lung 3 out of 3, cause neurotoxicity for patients. So that wouldn't have happened if a nurse put that pathway together, I'm just saying. But no, back to the transparency.
See, that's a good example, though, of how you need transparency
Yeah.
and some of the difficulties in terms of what is your endpoint that you're developing a pathway for.
Yeah.
Because many patients would not accept neuropathy.
Right.
Other people would not accept cardiac toxicity, but would be happy with not happy with neuropathy,
Yeah.
but more accepting of neuropathy. So yeah, again, it's empower the patient to make choices.
Yeah, so I'm gonna bring it back to this transparency thing, right? Because if I'm a patient and I need adjuvant therapy for lung cancer, so let's say I go to a bad actor, you're right, my physician may be being incentivized to prescribe one of these 3 agents. So all 3 are neurotoxic, period, right? Take a look, it's Taxol, Carbo, Gemcis, and Nabamune are the 3 choices in that pathway. And this isn't anything that Jen and I haven't had a conversation about. So the survey that Kim mentioned is a 50-question survey with patients trying to understand their access to care today versus a year ago, let's say. We have 700 responses. We asked 2 questions in particular about guidelines and pathways. So we said to the patients, are you aware if your treatment is being directed by a guideline? Second question, are you aware if your treatment is being directed by a pathway? So when you look at guidelines, 50% of the patients know that their treatment is being directed by a guideline. So that's very familiar with them and they feel comfortable with that. When you look at pathways, almost 60% say they are unaware if their treatment is being directed by a pathway, right? A full 60%. So if I'm a patient, my physician is being incented to follow a clinical pathway versus provide care, because I'm on board with the let's pay physicians to deliver care that patients are looking for, distress screening, care planning, those sort of things. In this situation, they're being paid to follow a drug pathway. And I'm a patient, I may be prescribed something that's not in the best interest. So I would just love to know what the panel really thinks about, the stats I just mentioned to you and what options are.
So first of all, Linda, I think there absolutely should be transparency, but first of all, that should come, and I'm not ducking, I'll talk about the provider side in a second, but frankly, that should come from the insurer side. The insurer basically should say to their beneficiary, I hate to use that word, but to their beneficiary, to that patient, basically, here is what this is all about, and that should be clear and transparent. So when I was talking and referring to Brian in terms of transparency, what I'm referring to and sort of stumbling over a little bit, because if you look at some of these pathways, you're going to have a patient not understand anything that you just said, except if they have lung cancer. So for example. So I think there has to be transparency across the board. I think this has to be very clear, and I can tell you right now, personally, and I'm executive director of COBE, we have not published a statement on this, but I have a big problem with the pay and the pathway thing. I have a big problem in general of paying physicians to do a certain thing as an incentive, because at the beginning of the day, physicians should treat the patient. The problem is, we set more and more barriers up. It comes from the Medicare side, from the private side, that physicians spend more time on crazy administrative things as not seeing the patient. That's what we have to get through. And by the way, if we don't get through this whole discussion is going to be moot, because as far as on the community physician side, because it will be in the hospital setting. It will all be in a hospital setting, because as you know, and everybody knows, that's where it could head. And that's more expensive for the patient, and you don't see some of the transparency there at all. So I totally agree with you. I absolutely agree. But I think, first of all, it's the responsibility of the payer. In the case of WellPoint, I think it's the responsibility of that payer to inform that beneficiary exactly what is happening, exactly what they're doing. And I think the provider has that onus as well, too. And I can tell you that some of the providers that are doing the WellPoint thing are being dragged a little kicking and screaming, even though it's open. It's open, but if you have WellPoint as a big payer, you're in a tough situation. So I'm of the belief also with IRA, although I don't want to wait 2 years, so we're going to make it happen sooner. It is wait till this shakes out. I think it will shake out. I think we have to force it to shake out now, not wait 2 years down the road.
Brian, can I just add to that quickly, since Linda and I share one brain, I think sometimes, but I think that the your point, Ted, too, it's the responsibility of the payers to commit to that transparency. The fact of the matter is they're not. And the fact of the matter is, one of the reasons that we want everybody to stay here at 2 o'clock today to continue with the conversation about what we as advocacy groups can do to educate consumers is that they're not. And I'll be honest with you, WellPoint's been very upfront with us about that they, when they rolled this program out, there was no companion program for the consumers. You asked the question, Brian, should we be giving patients these pathways? I think the first question is, should we be telling patients that there are pathways? I mean, step one is to be telling patients there are pathways. Step two is, patients are very uncomfortable to ask the doctor the question, are you getting a financial cash bonus to put me on this pathway? We have to give patients the language and the skills and the tools and the training to ask about the pathways, to ask about the incentive for the pathways. And then the last thing I'll say, and I know, Jeff, you have a question too, but the last thing I want to say is that I know when WellPoint rolled these out and down, I'm not picking on them in particular, just talking in general about the topic, but when they rolled these out, they called them clinical pathways. So we said, okay, these are clinical pathways. So what else is the physician incentivized for in the package of a clinical pathway? What other aspects of comprehensive cancer care are they being incentivized for through this cash bonus payment? They're not clinical pathways, they're drug pathways. I think clinical pathways, frankly, in this situation is a euphemism. If it's a drug pathway, let's call it a drug pathway, because they're being incentivized to stay within a particular drug protocol. So, why they did it, how they arrived at it, how they linked to the NCCN guidelines, those are all really important questions. But I would say the most important piece for us right now, particularly as advocacy groups, is we were trying to demand the transparency, and that's not happening, so we're going to lead the transparency for patients.
Appreciate the passion.
What, was that passionate?
No.
Can I get an amen?
Oh, and apparently Jeff has a question.
Yes.
I think I want to follow.
Yeah.
It's like creeping up. I guess I will ask a question though. To date, have these pathways, or is there a role for pathways to be constructed in a way that they are filling the evidentiary gaps that you all referred to, or are pathways simply existing to respond to the current state of knowledge and align that? I guess the first part of my question. And the second is are there any efforts underway currently, or is there desire between, if pathway proliferation is a problem and very confusing to practices, are there any efforts to harmonize it? Because it just seems strange. A couple of you referred to airlines as an example here. Wouldn't it be odd to be sitting on a United flight saying like, oh my God, they don't check the brakes on this before we start. I wish I was on US Air.
I think I'll try to take a little of that and then hand it off to Ted and Bob. The answer to question 2 is definitely yes. But there's another aspect to the question 2 that you have to take into account, which I'm sure Ted does when he goes home at night and talks to his wife, which is that if you're an oncology nurse and you are mixing chemo for 10 different doctors, you probably don't want 10 little subtle variations because you're going to get errors. So just think about office workflow and standardization and patients. Patients want error-free drugs, right? So technology is not bad. Let's not be Luddites about this. Let's understand the transformation happens, and it happens for a reason. Now, to question 1, I don't know if it was prescient or it was just the way we did it. We basically had an expert sort of kick the tires on our own, and then when the pathways companies that we used partnered with providers and markets, they brought together local experts to go and sit on committees to agree upon what they were going to do and what they were going to include and not include, that actually took into consideration, well, if you do this, do you want to have this many side effects? If you do this, do you want to have that many side effects? So it essentially was the provider buy-in on that made us feel like they were giving this in good faith. And most of the actual financial aspect of this had to do with hospitalization savings. Didn't have much to do with the drugs. Some to do with the drugs, but not much. Because like I said, everybody recognized that if you already knew what you were doing, you weren't going to change very much. So I don't know if that helped answer the question, but it was,
But
you know.
is there a role for research that's being built into any of your pathways as far as, we don't know which is better here, but can we incentivize the data collection so that in 3 years we'll be able to reach a determination and have a higher level of evidence so that we can make a justifiable next step as we update our pathway?
Well, let's put it this way. Ted gave the example of the person who really was one of the leaders in turning it into a business. And however nefarious that might have been, if that person had never done it or nobody had ever done it, we'd never have the data. Now we have the data. We can actually marry granular clinical information with outcomes information that has financial tags to it as well. We didn't have that 3-4 years ago.
And you know, I'll add on to that is that why I'm a big proponent in terms of physicians that are developing their own pathways, whether they purchase it and moderate it, modify it, whatever the case may be, or they actually create them and develop them, is again, it is a great information sharing tool with all the people involved, all of the clinicians involved in the practice. So it's actually upping the knowledge base of everybody. It's not just creating a cookbook. That's very important. And the other thing is that the practices that do that are also very involved in research, literally clinical research. So they're building that into the equation too, so that in a lot of these, an option is always available for someone who's in clinical research because they're actively involved in trials. And the last thing I'll say is, look, I'll never remember for the first time I had a discussion with my wife and said, let me ask you something, because she does all solid tumors. She's actually not mixing the chemo, but all solid tumors except non-female specific GYN. And I said, do your docs follow pathways? She said, what? I mean, this is an oncology nurse, you know, OCNs are everything else. So you have nurses that don't realize what are happening in some case in transparency of what's happening. I can tell you it's a practice that I know that are very progressive doing their own pathways. Everybody's invested. The nurses that are part of it, everybody's invested in the process. And frankly, it's sometimes the nurses who, and I'm not just saying this so some of you will go say nice things about me to my wife, but it's sometimes the nurses who are spotting the things like toxicities and things like that that may not be thought about right away by some of my oncologist friends.
So I think we have time for one more, unfortunately, maybe two.
Yeah, maybe two.
Okay, we got two.
I thought it was really interesting to hear, Dr. Carlson, how many of the pathways adhere to or use the NCCN guidelines. Where I got a bit confused though is, Dr. Klein, you were saying that you use the 1A level evidence in
No,
your...
when it's available.
When it's, okay, because then
We
you were
use the
saying what a
highest
small
level.
subset it is.
No, the highest level of evidence that is available.
Okay, so in other cases then, is it fair to say that when you get into the level 2A, 2B, and other, that that's where there probably is more variation in pathways? Because it is left more to the discretion of people putting
It
them together?
depends, because 65%, maybe a little less, is breast, lung, and colon. And I don't know, Bob, did you want to talk about that in terms of variance there versus variance for non-Hodgkin's lymphoma and
Yeah,
other
and
diseases?
that's the thing I would say is that night with the WellPoint again as the example with night they spread it into 19 cancers. So you have a lot of data that goes beyond the level 1 evidence, I think.
So we have done assessment of practice patterns, and in those situations where there is level 1 evidence, there is remarkable consistency across pathways, guidelines, multiple professional guidelines, and so on for recommendations. And if you actually look at care delivered, the care is almost always concordant with level 1 evidence. Level 2, it drops. Level 2B, it gets even lower. And then, of course, the category 3, where everybody disagrees, it's all over the map. One of the challenges with doing it with the pathway companies is, quite literally, I've tried to, I can't go to a pathway website and find out what their recommendations are. It's opaque. You can't do it unless you have a license. You know, I do know what some of them are because those who actually license our guidelines, we actually then require that they, and we make Ira's group work a lot on this, when they develop their own pathways based on our guidelines, we actually then verify that the outcome of their pathway system actually is concordant with our guideline. So we have indirect ways we can do that, but those aren't very straightforward or direct ways. And I'm not so sure that it's our responsibility to be sure that the pathway companies are concordant with each other. I mean, that's their product. It's their responsibility.
Okay, one more question in the back.
So have there been any comparisons that practices with a high level of concordance to NCCN guidelines are better outcomes or worse outcomes than practices that are involved in a Pathways program? I mean, has there been any comparison to Pathways versus NCCN concordance?
So let me broaden the question and then I'll narrow it. So if you look at any of the practice certification programs, to my knowledge, there is no meaningful evidence that any certification program makes squat worth of difference in terms of patient outcomes in those practices. So in other words, if you look at a COC or a COPE certified practice or not, and compare them with comparable size, comparable experience practices in similar socioeconomic status, settings, and so forth, I'm not aware of any evidence that the outcomes are truly different.
I actually, you know what, I just remembered, I have an answer to that. I told you that from 2010 on, we did a series of pathways, pilots across the country using different methodologies. One of them was with a company that had all NCCN guideline treatments available. And there was no guidance given. And there was absolutely no economics involved either. It was basically something that was given to the practices, and we said, use this, we'll check this, and the only incentive was, we'll try to help make where there is a pre-auth, because there's not that actually much pre-auth, but where there, at least for us, where there is pre-auth, we'll help speed it through. So we gave them sort of fast-track pre-auth. And what we found was, in doing a pre-post analysis, prior to the implementation of the software, which had no specific cone-down pathways, it just had all NCCN guideline choices available, adherence to NCCN guidelines, this is all cancers, was about 60%. In a 12-month study, adherence to NCCN guidelines after the software was implemented was, I think, 82%. So even without economic incentives, it works.
But was the outcome different?
Oh, we don't know.
Was the question, was the outcome different? Now, there have been about a dozen studies that look at, they're retrospective studies, and they look at, in retrospect, was therapy concordant with this guideline versus that guideline? And there are about 3 or 4 that have been done with NCCN guidelines. There are other guidelines or pathway systems that those studies have also been done on. Every single one of those studies that's ever been published, to my knowledge, has shown either improvement in a disease-oriented outcome or lower cost or both. But those are all retrospective, non-randomized sorts of approaches.
Okay, so this has been, I know we could talk about this all day, it's so much fun, but it's been really enlightening, and that's kind of the definition of great panelists. You really provide a great education. So can I ask that we all thank our panelists?